So hello, my name is George Minawata. I'm a volunteer pulmonologist for the MAVEN Project. Thank you all for attending and being part of the MAVEN Project. I especially want to thank our friends at the Holyoke Health Center in Holyoke, Massachusetts for hosting today's session, A to Z of EKGs with Dr. Charles Schulman. A little bit about Dr. Schulman. He was an assistant clinical professor of medicine at Harvard Medical School from 1988 to 2016. He's currently a corresponding member of the faculty of Harvard Medical School and a senior physician at the Beth Israel Deaconess Medical Center in Boston. He's been practicing non-invasive cardiology since 1970. His scientific articles and abstracts have appeared in the New England Journal of Medicine, Circulation, the American Journal of Cardiology, and the British Heart Journal. His research interests include the treatment of hypertension, congestive heart failure, and hyperlipidemia. And with that, Dr. Schulman, the floor, or I guess the screen, is yours.
Thank you, George. And good afternoon to everybody in Holyoke. And if you're in San Francisco, good morning. This talk is it's kind of an overview of EKGs. You certainly can't present everything there is to present about EKGs in an hour, much less 3 hours, or much less a whole course. So I have selected certain points to emphasize as we do this. Why will my slides not advance? There we go. Okay. So I have no disclosures, nor does anybody else that has had anything to do with this session. And the accreditation is for one category 1, 1 hour of category 1 credit for physicians. What I hope to do is improve your understanding of the anatomy and blood supply of the conduction system, and to go over the formation of the clinical electrocardiogram. We hope to have you recognize normal rhythm, atrial fibrillation, bundle branch block, and some heart block. To know the location of myocardial infarction, and to recognize some risk factors for at least one of the serious ventricular arrhythmias. This is a picture of the subject of Dr. Einthoven's original electrocardiogram, which he discovered, or well, which he invented really, in 1899, and for which he received a Nobel Prize in Medicine in 1924. And you see this rather unhappy looking fellow with his 2 hands in buckets of saline. We, of course, advanced a great deal since that time. Now, the anatomy of the conduction system is as follows. Let me get a pointer on. Pointer is here we go. Okay, misbehave. Okay, so the cardiac impulse begins at the sinoauricular node, the SA node, which is located between the superior vena cava and the superior portion of the right atrium. Impulses travel through the atria, that's not depicted here, to the AV node, located in the interventricular septum, then to the common bundle, then the bundle branches, then to the his Purkinje system. The Blood supply for those structures is as follows. In 60% of people, the SA node is fed by the right coronary artery, 40% by the left circumflex artery. The AV node, however, is fed 90% of people from the right coronary artery. The right bundle branch and the left anterior fascicle of the left bundle branch are fed by the left anterior descending coronary artery, and the posterior fascicle has a mixed blood supply. And so this depicts these two illustrations depict the result of the traverse of the impulse from SA node to ventricles and recovery on the clinical electrocardiogram that we see. So the SA node does not cause a deviation from the baseline. As the impulse travels through the atrium, it creates what we call the P wave. And when it arrives at the AV node, there's an apparent pause, but there's no deviation from the baseline. And then the QRS is ventricular depolarization, followed by the ST segment and T wave, which represent recovery. The initial, when you, there are limb leads and chest leads, and the chest leads, as shown here, illustrate that the initial depolarization of the ventricles, plural, is from left to right, so that in lead V1, which is located on the right side of the chest, there's a positive deflection, and in V6 there's a small negative deflection called the Q wave. That's followed by a large vector toward the left, so that there's a negative deflection in the V1 and a positive deflection in V6. The basic principle here is that when the vector travels toward the electrode, there'll be a positive deflection, and when it travels away from the electrode, there will be a negative deflection. And as you go from V1 through V6, there is what's called normal R wave progression. The R waves gradually increase in height to about V4, V5, and then out laterally, it diminishes. You can calculate axis in the frontal plane with the limb leads by using leads 1 and AVF. Those are the easiest ones to use because they are perpendicular. So if you have positive in lead 1 and positive in lead F, that will lead to this kind of a vector right here, positive in lead 1, positive in lead F, and the axis is normal. If it's negative in lead 1 and positive in lead AVF, that will be right axis deviation. If it's positive in lead 1 and negative in lead AVF, that will go in this direction. And then there's this extreme right axis deviation, also called no man's land, negative in 1 and negative in AF and AVF, or also called northwest axis. And to illustrate, this is a picture of the Seattle Space Needle. Now, we recommend that we take a systemic approach to the interpretation of an EKG or ECG, right? It's EKG is German, ECG is English. And so first you figure out rate, figure out rhythm. Is it regular or not regular? And then is it fast, normal, or slow? What the intervals are, calculate the axis, figure out if there's chamber enlargement or hypertrophy, and then if there is ischemia or infarction. And so this is a normal rhythm, normal sinus rhythm illustrated here. And the intervals are the PR interval is up to 200 millisecond. Oh, well, let's do it this way. Each of these small boxes represents 40 milliseconds, and each large box represents 200 milliseconds. So that and, you know, the PR interval should be less than one large box. The QRS is less than 3 small boxes, 120 milliseconds, and the QT interval should be less than 470 in men and 480 in women. You can estimate heart rate, because the standard paper speed is 25 millimeters a second. So if you mark off one part of a QRS complex, as shown here, then this is and if the next QRS is here, that's a rate of 300, 150, 100, 75, 60, 50, 43. So if we go over here, we can count the heart rate here. 300, 150, 175. So the heart rate illustrated here is 75 beats per minute. We also recommend a systemic approach to arrhythmia interpretation. Look for P waves. Is the QRS wide or not? Wide or narrow? What is the rate? What is the ventricular rate? What is the atrial rate? Are they the same or different? Is there a regularity? Are they regular or not? And are the P waves and QRS complexes related to each other or not? So here's a normal cardiogram. The axis is normal, right? Positive here, positive here. The PR interval is about a little bit less than one large box, less than 200 milliseconds. The QRS is probably two small boxes, or about 80 milliseconds, and the QT interval is about 360, something like that. Okay, then there is normal R wave progression. There's a small one, larger, about possibly a little larger, perhaps the same. Okay, so this is a normal ECG. The ST segment is not deviated one way or the other, and T waves are all upright. So here's another one with a different axis. You notice that the PR interval is long here, right? It's probably 280 milliseconds, right? One large box into a couple of small ones. So that would be, okay, the heart rate is a little under 100. The QRS is narrow, but what's the axis? It's positive in one, but very negative in AVF. So away from AVF would put it up here. Positive in one would put it to the right of the vertical, and negative in AVF would put it above the horizontal, which would put it in here somewhere. Left axis deviation. How about this one? Negative in one, positive in AVF. So negative in one would be on this side of the vertical, and positive in AVF would put it down here somewhere, making this right axis deviation. Okay, so here's a lady that came into our clinic one day complaining of a cough. Her daughter thought she needed an antibiotic. She had no fever, no chill, no sputum, but she was short of breath. This shows a rapid rhythm. See the rate is actually, this is not a regular rhythm, is it? So So the rate, if you calculate it from here, this will be a little under 150. You calculate it here, it'll be a little under 100. But so with this arrhythmia, you want to take a whole minute and count the entire minute. Now the computer read this as sinus tachycardia with PACs, but in fact this is atrial fibrillation with with all these little teeny P waves that you can see here in V1. Okay, so rapid, irregular, narrow complex tachycardia is almost surely atrial fibrillation. And this shows the pathophysiology of atrial fibrillation. If you compare the impulse to a normal, this shows a normal impulse traveling from SA node to AV node to his Purkinje system. This shows upwards of 360 reentry circuits in the left atrium bombarding the AV node. And because some of the impulses are more or less conducted through the AV node, there is more or less refractoriness and therefore an irregular heart rate. Atrial fibrillation is the commonest arrhythmia that we see, both in wherever your clinic is, in my clinic, in the hospital, in the electrophysiology laboratory. So it's a very common problem. And these are some of the principles of the management of atrial fibrillation. One is to assess and treat stroke risk. So that's first. Then optimize modifiable risk factors like heart failure, obesity, arterial hypertension, diabetes, sleep, especially sleep apnea. Then make some decision about symptom management and atrial fibrillation burden. Atrial fibrillation burden refers to the amount of time that you're actually in atrial fibrillation as opposed to sinus rhythm, and decide about either rhythm control or rate control. Okay, now turning to the heart block poem. This is one of my favorite slides, the heart block poem. If the R is far from P, then you have a first degree. Longer, longer, longer drop, then you have a winky Bach. If some P's don't get through, then you have a Mogut's 2. If P's and Q's don't agree, then you have a third degree. So there are 3 degrees of AV block. First degree, second degree, where every P wave is conducted. Second degree, where some are conducted and some are not. And third degree, where none are conducted. Okay, so here are 2 patients who have heart block. This one. So you have this PR interval, then this PR interval, then a drop beat. This one down here, where you have this PR interval, which is the same, and then a drop beat. So one of these needs a pacemaker. Do you know which one? Put it in the chat. Put your answer in the chat. Okay, we'll go on. We got some answers. Let's see what answers we got. B. You're all right. That is all correct. Well, come on. There we go. Okay, so this shows the difference between what's called type 1 and type 2 block. Dr. Wenckebach described the block which carries his name, where there is an increase in the PR interval from 20 to 30 to 35 to a drop beat. That carries his name. Then in the 1920s, Dr. Mobitz recognized that there was a different kind of second degree AV block where the PR intervals didn't change, 20, 20, 20 drop beat. So this is Mobitz 2. This is called Mobitz 1 or Wenckebach. And the differences anatomically are that type 1 or Wenckebach occurs in the AV node, and type 2 occurs in the His-Purkinje system. And so this is all or nothing. Whereas this has to do with relative refractoriness. You'll notice that the PR interval after the pause is shorter than before the pause. Well, that's a characteristic of Wenckebach conduction. If you have every other beat, then you may want to know whether it's Mobitz 1 or Mobitz 2. So you ask the patient to exercise. So here's my patient, who was at the time 69 years old. He has heart block. Here's this PR interval, this longer PR interval, and a drop beat. So he has Wenckebach conduction. And then when he exercises on the express test, he has 1-to-1 conduction. This is sinus tachycardia, right? 1-to-1. Yeah, every QRS is preceded by a P wave. So conduction improves with exercise in Wenckebach. On the other hand, this is one of the consequences of Mobitz 2 conduction, right? So here's sinus rhythm, PR intervals don't change, and all of a sudden you have no conduction at all. Followed by conduction with the same PR interval. So this person certainly needs a pacemaker. Now here's a 72-year-old woman who presented with syncope and then complained of chest pain. And the baseline is there's a little baseline wander here. But if you look at the heart rate, you notice that the PR intervals are all different. And that's because none of the P waves are conducted. The atrial rate, you can calculate right here, 300, 150, 100. So there's almost a sinus tachycardia, but the ventricular rate is in the 40s maybe, or slower. 300, 150, 100, 75, 60, 50, 43, 37. So the ventricular rate is 37, but the atrial rate is 100. So this is complete heart block. The atrial depolarizations have nothing to do with the ventricular depolarizations. And that's because what you can see here is ST elevation and leads 2, 3, and AVF, which are consistent with an inferior myocardial infarction. So these are the ECG anatomic locations supplying coronary arteries of infarction. So 2, 3, and AVF is inferior. The V1 through V4 is anterior, the left anterior descending coronary artery. This is usually the right coronary artery inferior. 1 and AVL can be lateral, an LAD diagonal, or a left circumflex, and then this is considered lateral out here. So here we saw an inferior MI due to right coronary artery occlusion. And the reason that there's heart block is because the right coronary artery in 90% of people feeds the AV node. So this is the heart block is due to AV nodal ischemia. Usually you don't need a pacemaker for this kind of thing. It resolves on its own. Now here's a 67-year-old woman who complained of palpitations and shortness of breath, and she has an irregular rhythm with no visible P waves. So this is consistent with atrial fibrillation, followed by a long pause. So what happens is the atrial fibrillation converts, and the SA node doesn't pick up again until you get over here somewhere. There you go. There's sinus rhythm over here. So this is what's called a conversion pause or sinus nodal dysfunction, and the tachycardia and bradycardia make this tachycardia bradycardia syndrome. So in order to treat the tachycardia, you need a pacemaker, because any of the rate slowing drugs will make this worse. So you need a pacemaker and then deal with the atrial fibrillation. Now, if we think about bundle branch anatomy, normal conduction goes from SA node to AV node to the common bundle and down both bundle branches to the Purkinje system. This is all simultaneous. With right bundle branch block, depicted here, impulse goes to the left ventricle and then secondarily heads to the right. Whereas with left bundle branch block, it goes to the right ventricle and then secondarily to the left. And that gives these characteristics of appearances on the electrocardiogram. So for right bundle branch block, if you look in V1, which is located on the right side of the sternum, you see that there's an initial R wave, then followed by an S wave, and then a secondary R wave called R prime. This is the abnormal deflection, and it's headed toward the right. There may be a small S wave in V6 as well. Whereas with V1, with left bundle branch block, V1 looks like this. There may or may not be a small R wave, followed mainly by an S wave. Right. So the simple way of deciding whether you have right or left bundle branch block is to look at V1. If it's up, it's right. If it's down, it's left. Easy. All right. So here we have a normal sinus rhythm with bundle branch block. Which one is this? Right or left? Okay. Want to put it in the chat? Anna says right, and she is correct. Right, this is right bundle branch block. Typical right bundle branch block. Okay, here's another one. Wide QRS complex, negative in V1. And so is this right or left bundle? Marianne says left, and she's correct. I didn't want to say and she's right because it's left. She is correct. Okay. Now this is just kind of an overview of ST segment abnormalities. There is the ST segment elevations can be either concave upward, like this, which is really normal early repolarization, or straight or convex, right? Think of this as a smiley face and this is a frowny face. And this suggests this suggests infarction. And then for ST segment depression, it can be either upsloping or horizontal or downsloping, according. Now here's a 49-year-old man who awakened from sleep with 30 minutes of left-sided chest pain, which then subsided. So he's now pain-free, arrives at the emergency room, has a normal examination, and this electrocardiogram. What's abnormal about this electrocardiogram? Well, it has normal sinus rhythm, it has narrow QRS complexes, but you'll notice that there are T-wave inversions in B2, B3, and B4. Okay, see that? 45 minutes later, the chest pain recurred in the emergency room, and now look at what you have. ST segment elevation in B2, 3, 4, 5, 6. A little bit in L, not so much in 1, not in 1, really. Okay, so this is consistent with occlusion in the left anterior descending coronary artery, occlusion or extremely tight narrowing. This is consistent with an anterior infarction, according to the chart that I showed you a few slides ago. And there's the lesion right there, that coronary angiogram. The explanation, and so those T-wave inversions in B2, 3, 4 were described by Dr. Hein Wellens, a Dutch cardiologist, who described a series of cases where people came in with chest pain that had resolved, and then they had these T-wave inversions. And if revascularization was not undertaken, they went on to have large anterior infarctions. And so the explanation for that is as follows. In the olden days, before revascularization, the evolution of the electrocardiogram in a ST segment elevation MI was as follows. The first change is a hyperacute T wave, followed by ST elevation, followed by Q wave developing, and then the ST segments come down, the T wave inverts. The T wave may eventually recover, but you still have a Q wave. In 2024, however, people who come in with this appearance go to the cath lab and have a stent placed in the appropriate artery, after which there are these T-wave inversions that are thought to be reperfusion T-waves. And so the explanation for Wellens, what's called Wellens warning, is that there's an occlusion which causes the initial chest pain, and then reperfusion, although the lesion is still unstable. And so you should, we should act promptly in trying to achieve revascularization for that person. All right. Now, next case is a 68-year-old woman who complained of shortness of breath and palpitations for a week. She has a history of hypertension, chronic kidney disease, and arteriosclerotic coronary artery disease with a previous non-ST elevation MI and a stent. And here's her rhythm. And although you can't calculate the rate because there are no markings on here, you can see that this is a narrow complex and it's irregularly irregular at a rapid rate. So this is what? atrial fibrillation. Exactly, atrial fibrillation. Okay, so she's treated. Let's close this. She's treated, she's anticoagulated, she's cardioverted to normal sinus rhythm and feels great. 6 months later, however, symptomatic atrial fibrillation recurs, and she was treated with sotalol, one of the antiarrhythmic drugs, 80 milligrams BID, standard dose. And then she was cardioverted again. She again felt well, but returned after 2 episodes of syncope. And her electrocardiogram is shown here on arrival. He has normal sinus rhythm, but she has very prominent what? Yes, really long QT interval. Right? Normal QT is less than half of the RR. Long QT is more than half of the RR. There's not much question about this. It's, starts here and ends way over here, almost on top of the next P wave. Okay, so this is prolonged QT, and what is the arrhythmia that she's likely to have had that caused her syncopal episodes? Do you know? VTAC. Well, yes, that's true, but what kind of VTAC? And the answer is torsade de pointe, torsion of the points, or polymorphic VT. Okay, and here are examples of polymorphic VT. You notice that the arrhythmia starts on top of the T wave, right? The vulnerable period. And torsade de pointe is the points go down, then up, then down in the same lead. It's short-lived until it deteriorates to ventricular fibrillation, for which she was cardioverted. Not cardioverted, she was defibrillated. Okay. In terms of treating her atrial fibrillation, drugs will not do the trick, and she should have an ablation of her atrial fibrillation. But in terms of the torsade, there are a number of clinically recognizable risk factors. Prolonged QT prolonging drugs, concomitant use of more than one QT prolonging drug, heart disease, heart failure, acute MI, advanced age, and what I call the 3 hypos: hypokalemia, hypomagnesemia, hypocalcemia. This is just a small sample in the list of drugs which are capable of leading to torsade de pointe. The actual list is about 1.5 pages, single-spaced. But there are a number of drug classes which are commonly associated with it, including antiarrhythmic drugs. So this is the most common, and I shouldn't say the most common, but it's certainly the most dangerous side effect of the antiarrhythmic drugs. Here's sotalol, right here. Dofetilide, amiodarone. Amiodarone is actually much less. Antibiotics, the levofloxacin, ciprofloxacin, azithromycin, erythromycin, chloranthromycin, the antifungal azoles, antidepressants, some listed here, and other drugs, including tyrosine kinase inhibitors, methadone, arsenic, sumatriptan, and no densitron. Okay, and so now we get to the zebra. When you hear hoofbeats on the roof on Christmas Eve, which is it more likely to be? Santa Claus's reindeer or a zebra? A pretty obvious answer. I won't say it. I won't say it. It will be left unsaid. But zebras are so uncommon that we refer to rare diseases or rare problems as zebras. All right. That takes us to the next ECG, a 47-year-old asymptomatic man with a previous inferior MI that I saw in clinic one day and had this electrocardiogram. Now this has an extremely strange axis. The extremely strange axis is minus 180. Okay, right there. That's highly unusual and clearly not normal, right? What's it due to? Well, if you look at the R wave progression is relatively normal. So this is due to the commonest cause of this kind of thing is due to reversed arm leads, right? In the limb leads, this is a reversal of the left arm and the right arm. So normally the left arm looks like this and the right arm looks like this. But if you reverse arm leads, those are just the opposite. And when we redid the cardiogram, we found that his axis is absolutely normal. Okay, so the previous ECG was due to reversed arm leads, which is the commonest cause of that sort of thing. Now here's another man, a 66-year-old man, who presented with a 3-day history of cough, congestion, and pain in the chest, and his axis is about the same. Whoops, sorry, right? It's about the same as the other one. However, look at the limb lead, look at the chest leads. What do you see? As you go across the precordium, the impulses get smaller, not larger. Why is that? There's the explanation. His heart is located in his right chest and not his left chest. He has dextrocardia or situs inversus. Okay, and so you'd have to take the chest leads on the right side in order to have them be normal. I guess I've impressed Mary Ann. So here's our zebra for today. Okay, dextrocardia. And in fact, I think we've come to the end of our time. And so this is my parting shot right there.
Great. Thanks, Dr. Schulman, for a great talk.
Right, there you go, folks. If there are any questions, I'm happy to answer them. Yeah, you can either put them in the chat or.
Dr. Schulman, while people are getting their questions together, can I ask you to comment on a couple things on the bundle branch? You may have mentioned it, and I might have missed it on the cure restoration for bundle branch, and then also evaluation of ischemia or the ST changes in right versus left bundle.
Well, in order to diagnose right bundle, either bundle branch block, the QRS complex should be greater than, equal to or greater than 120 milliseconds. I think that's the answer to that part of it.
I wasn't sure if you'd mentioned the Weidman QRS.
Yeah, it's 120. It's 120 milliseconds.
Okay.
In bundle branch block, there are repolarization changes which are due to the depolarization changes. I can show you. You want? Do we have time for an example? Yeah, we do.
Sure.
Okay.
Yeah.
Okay. Hang on. Hang on. I'll be right there. And there we go. That's not it. This is it. That. Okay. So I've already shown you this. Okay.
Mhm.
And I've shown you this. All right. This is left bundle branch block. This is right bundle branch block. Okay. Now the STT abnormalities are as follows. They are in a direction opposite the major QRS abnormality. So if you look in V1, the abnormality is this secondary R wave, which is upright. Therefore, the ST segments should be down and the T wave should be inverted. If you look at a typical left bundle branch block, the QRS major deflection is down, the ST segments should be up. Okay. Well, if you look in V6, the QRS is upright. Therefore, ST segment and T wave are down. Okay, so here's somebody who has a right bundle branch block. Okay, but he's also got something else, doesn't he? His ST segments are going in the wrong direction. They should be going down, not up. And so what does he have? He has an anterior STEMI. Here's a lady who came in with chest pain, who had a left bundle branch block. Here's her usual left bundle branch block. Okay, looks like typical left bundle branch block. But look here with chest pain. What do you see? In lead 2, there's ST elevation, which should be ST depression, not okay. And the V2, this is the obvious one that struck me. Okay. The sagging ST depression is abnormal. It's going in the wrong direction. Should be upright like that. So those are the repolarization changes to look out for.
So to summarize, so in right bundle, an ST elevation MI, in the setting of chest pain, the EKG, it's pretty straightforward. In left bundle, someone with chest pain and it's due to, ischemia, the changes are going to be subtle, or can they sometimes, or not infrequently, not be there in the setting of left?
They can be not there. Yes, they can be not present. One of the criteria for an acute STEMI or an acute occlusion MI is the new onset of left bundle. Right. So if the previous tracing didn't show left bundle at all, and patient comes in with chest pain and a left bundle, then that may be an indication of a new cardiac event. But the changes can be a lot more subtle. That would be true. Here, can you see this?
Yes.
Okay. Can you see this? So here, for example, in leads 3 and AVF, the QRS is down, the ST segment and T wave are up. Okay, which I mean, it's not so obvious until you compare it with her baseline. I'm not advancing. I don't know what's going on here. Come on. Well,
yeah, we can. I don't know if everyone else.
There you go.
There it goes. See,
you see here. So this is more normal. This is down. This is up slightly. Okay. This is down. This is up a lot. But that's harder to differentiate, except when you look here, it's much more obvious that it's going in the wrong direction.
Yep.
Okay.
Yes. Okay, I think there might be a question in the chat and I can't I'm trying to get to scroll all the way to the bottom. Oh, here we go. Let's see. Nope. I don't think there are any other questions from anybody.
Okay.
Hey, the one thing, I guess, one more quick question. When you showed the AFib with the rapid ventricular rate, there was ST depressions in some of the V leads on that EKG, and you didn't mention anything about rate-related ischemia, how concerned someone should be in that, because they disappeared when you controlled the rate on the following EKG. Can you comment on that?
Yeah, it's in that setting. Is this the one you're referring to? Oh, well, wait a minute. I have to share my screen. I'm not doing it. Well, all right. Let me. Is this the one you're referring to?
No. There was another one where you, yeah, where you were showing rapid AFib and there were ST depressions. in the V2, V3, something like that. And then the next slide you showed the rate was controlled and the ST depressions were gone.
Maybe you're thinking of this? No, but that's sinus rhythm.
No, it was an AFib. You talked about AFib.
Yeah, well, okay. I can't find it, but I'll answer. Let me answer your question.
Yeah.
There often are non-specific STT abnormalities with a rapid rate. Um, uh, um, although it is pretty unusual to have ischemia as a cause of rapid AFib. It's not impossible, but it's pretty unlikely. So we advise people to not rule, to not rule out ischemia every time a patient who happens to have paroxysmal AF shows up with AFib. Because it's generally not due to ischemia, it's due to the AFib.
But when you see those rate-related ST depressions, you shouldn't get too hot and bothered about ischemia, in other words. You want to control the rate. The issue is control the rate. Don't give them lytics or send them to the cath lab and get a stent or something like that, or call the interventional cardiologist. Control the rate is kind of the take-home message, right?
So I think that's right. You want to control the rate. You want to control the rate. Grab a troponin.
Yeah.
If the troponin is negative, which it almost always is. Now, having said that, I do have a patient who had very rapid AFib and chest pain. And with the chest pain, he turned out to rule in. But usually that is not the case. Okay. That's an unusual case.
Okay, I don't see any other questions. I think we'll wrap it up. Again, Dr. Schulman, thank you very much for a great talk and discussion. Thanks again to the Holyoke Health Clinic for hosting the session, and thank all of you for attending. And again, please submit your CME information when you get the links after you at the close of this webinar. And if there are other topics, or if your clinic wants to host some other topics or related topics, please contact Kristen Talbot. Thanks again. And with that, I'll stop the recording, and everyone have a good rest of your day.
Okay, take care. Thank you.